Good evening. Today I would like to discuss about the heparin infusion protocol for hospitalized patients. When the patients are at the hospital, oftentimes they are immobile. They don't move normally the way they used to move at the other time. So the patient needs to be placed on heparin infusion so that they don't develop stroke. And there are some patients for which the heparin infusion becomes more important. They are like acute coronary syndrome, atrial fibrillation, patients with DVT, PE, or transient ischemic attack, cerebrovascular accident. These are some of the patients that may need to be placed on heparin infusion. Heparin infusion can be done by two different way, heparin protocol by two different way. One is by aPTT level, activated partial thermoplastin time, or anti-10A level. One of the advantages of heparin infusion is that heparin being short half-life, it removes or eliminates from the body quickly. So if the patient needs to go for any surgery or operation, then the heparin drip can be held for a couple of hours based on the doctor's preference, and the patient can go for the surgery or operation that they need. First, we will discuss about the heparin infusion protocol by the aPTT level, activated partial thermoplastin time, and then we'll discuss about the heparin infusion by anti-10A levels. This is the first page of two-page heparin infusion protocol when heparin infusion is used for cardiac indications like acute coronary syndrome or atrial fibrillation, or when the heparin drip is used for DVT-PE, deep vein thrombosis, or pulmonary embolism. This protocol is based on aPTT level, which is activated partial thermoplastin time. For using this protocol, we need the patient weight in kilogram, not in pound, because the protocol calculates the heparin drip rate based on kilogram. Before the drip is started, we need to make sure some of the parenteral anticoagulants, if the patients are already on, to be discontinued so that there is no therapeutic duplication. If the patients were already on low molecular weight heparin or Eliquis, then heparin drip should be started at least 12 hours from the last dose of low molecular weight heparin or APIC7. Or if the heparin drip is starting after when the patient is already on Xarelto, Sabaisa or Arixta, then it should be started 24 hours after the last dose of Xarelto, Sabaisa or Arixta. That's because the last dose of those medicines should last for that many hours before you should start the heparin drip protocol. For this protocol, some labs are needed like STAT, aPTT, activated partial thermoplastin time, INR, and CBC prior to starting the heparin infusion. Then aPTT level should be checked every 6 hours when the heparin drip is running, and every morning when the patient is on heparin drip, they need the aPTT level. CBC count daily for first 3 days, and then every 3 days if they are still on heparin drip. Patient's platelet count should be monitored so that it doesn't go very low, and if INR goes over 2, then the nurse should contact the physicians. And if the patient has any signs of bleeding like hematocrit dropping or platelet count dropping like 50,000 from the baseline, then the physician should be informed. Patient's blood pressure should be checked when they are on heparin infusion. If the blood pressure diastolic goes over 105 or systolic goes over 200, then heparin infusion should be on hold and physician should be informed. Heparin infusion can be resumed again when the blood pressure falls 180 over 95, if not discontinued by the physician. On the second page of this protocol, we can see how this protocol is used for calculating heparin infusion rate based on different indications. If the physician ordered this for cardiac indications like SCS or AFib, then he or she may want a bolus or not want a bolus. If they want a bolus, that will be 60 units per kg, and the drip will start at 12 units per kg per hour. If they want this for DBT and PE, the bolus will be 80 units per kg and the drip will be 18 units per kg per hour. In case of cardiac indications, the maximum initial infusion rate should not cross over 20 ml per hour, and for DVT-PE, the maximum initial infusion rate should not cross over 40 ml per hour. Here you can see how based on aPTT level, how heparin infusion rate is adjusted. Sometimes the bolus may be needed for the patient, and based on the aPTT level, the heparin infusion rate may need to be increased or decreased, and it also tells when the patient next aPTT level should be checked. This is the one-page protocol of heparin infusion protocol when it is ordered for neuro indications like TIA or stroke. The main difference of this protocol with the other protocol that I just showed, which was for cardiovascular or DVTP indication, is that there is no bolus on this protocol and the drip start at 12 units per kg per hour. There's little difference in the adjustment of the rate, heparin infusion rate based on aPTT on this protocol compared to the other protocol that I just showed. Now we are going to discuss about the heparin infusion protocol based on anti-TNA levels. Some of the advantages of doing heparin infusion by anti-TNA levels are it takes less time to get to the therapeutic level, or it also takes less lab draws. This is why it's now being practiced at the hospitals nowadays. It can be based on three different categories of indications. One is arterial or venous thromboembolism, or ACS or AFib, and the third one is cerebrovascular accident or TIA, or when the patient has high bleeding risk, or like postoperative management. Based on these three categories of indication, the goal anti-TNA levels are different. You'll be able to see that in the protocol that I'm just going to show right now, and how based on the anti-TNA levels, the heparin infusion rate is adjusted based on this anti-TNA level protocol. This is in short a description about the heparin infusion protocol. Please subscribe, and I would like to see you guys with a different topic next time. Thank you.